Careblazers, I have the most special guest joining us today. Many of you will already know her. Her name is Julie McFadden, but you might know her better as Hospice Nurse Julie.
Hey guys, I'm Hospice Nurse Julie. I'm here to change the way we look at death and dying.
She has over 1.4 million followers on social media, and she's dedicated her time to educating and demystifying what it's like to die. Today, she joins us on the channel to talk about how it looks at the end of life when people with dementia die. We talk about hospice, the role they play, and what you can do if your loved one doesn't qualify for hospice but could still use a lot of support. She's coming out with a new book, which will be released in June. You can pre-order it now. I know many of you Careblazers already have. I've linked it in the description below. Careblazer, let's welcome Hospice Nurse Julie. Be sure to leave her some love in the comments below. Careblazers, I am so excited to share with you this amazing guest we have today who needs no introduction. Many of you already know her, but just in case you don't, Hospice Nurse Julie is here with us. Julie, I'm so honored to have you here. Our Careblazers love you. And can you just take a moment to briefly introduce yourself to maybe people out there who aren't aware of you?
Yes, of course. And thank you for having me. I am excited to be here and talk to you. So this will be great. So my name is Julie McFadden. I'm also known as Hospice Nurse Julie. On YouTube and Instagram and TikTok, basically wherever you get your social media information, I go as Hospice Nurse Julie. And I'm a hospice nurse and death and dying educator. And I'm trying generally to change the way we look and feel about death and dying through education. And that's what I've been doing for the past almost 3 years on the internet. It's been going really well, surprisingly, in the sense of in my everyday life, if I try to talk about death and dying to people, it's usually like, ugh. But on the internet, it seems like people are ready and willing to hear. So it's been really great.
I love that. It's such a needed conversation. There's so much fear and stigma and uncertainty whenever we're talking about death and dying, despite the fact that it's going to happen to all of us. So I love that you're able to talk about it and share real life experiences and help family members know what to expect. I was wondering if we could just start out, because I know there's a lot of confusion on this. Can you talk about hospice versus palliative care?
Yes. So that is probably my most frequently asked question. And I will answer it here in a general way, but just side note, I do have like 2 or 3 long videos on my YouTube page talking about this specifically because it is, I would say it's complicated. Like it's kind of a technical answer, right? So to really technically get into it, it would take like 20 minutes.
Okay.
And I don't want to do that to you or to anyone else.
I'll be sure to link those videos in the description below. But
Perfect.
I think the big thing is that a lot of people, when they hear palliative care, they're like, oh no, my loved one's about to die.
Exactly.
And so can we just clear that up?
Yes. And I think a lot of people think, oh, palliative care is a step before hospice. I even hear other nurses and physicians say stuff like that because it kind of is. I get what they're saying. Sometimes people on palliative care do go on hospice, but not always. And it's truly 2 different programs. To me, palliative care is like always a no-brainer, always and forever. Like anyone diagnosed with any kind of like life-limiting illness or chronic illness or terminal illness, or technically terminal, right? Like you may be dying from this disease, even if it's 15 years from now, they should be on palliative care immediately because palliative care basically sets a team of people, doctor, nurse, social worker, into your care world, right? Where they're going to help like manage all of the symptoms from that disease or all of the symptoms from the treatment you're getting for that disease. And they will help with the emotional side of the disease, the spiritual side of what's going on, like whatever you kind of want. It's like a more well-rounded program of like, they're looking at you as a whole person versus just like one little thing.
Yes.
So it's more of a symptom management program. Also, it can be funded differently. So depending on like where you're getting it from, how your facility or hospital works, you can do it inpatient. Some people can get on what your insurance is. Also, you don't have to be like, some people will say you have to have less than a year to live to be on palliative care. There's no need to have a terminal illness. It's just about having a chronic illness. So that's why it's a gray area. 100% speaking, they're not the same. Hospice is a end of life program where a doctor has said you have less than 6 months to live. We can go into like all the criteria in order to be on hospice too, but they're two separate things. They are not hand in hand, even though many people try to make them hand in hand. They're not.
Yeah, I think a lot of times when people talk about hospice, it's always clumped, many times it's clumped with palliative care, hospice. And so a lot of people who talk to me, when they hear palliative care, they get really scared thinking their loved one's going to die in a couple of weeks. And that's not necessarily the case. So thank you for clearing that up. I've watched many of your videos on social media. You talk about end of life a lot. I am wondering about the role hospice plays specifically for people who have dementia. Can you speak to that?
Yes. Dementia is just so tough. Anything under the dementia umbrella, right? Which is like all different types of dementia, and then Alzheimer's and Parkinson's can be under there too. So like we don't see those patients with those diagnoses or those diseases until the very, very end stage. Some hospices, I will say, are a little more lenient than others. Like I've worked for a hospice before that would let people on service that didn't technically meet criteria for dementia or Alzheimer's. Whether that's good or bad, like it's neither here nor there. It's just like we technically all should follow Medicare guidelines, right? Medicare will give us specific guidelines for the diagnosis of dementia or Alzheimer's or Parkinson's. It's kind of all lumped into one, and there's very specific criteria that allows us to allow them onto service. It can be difficult, and that is the population as well that can come off hospice a lot. So usually what happens is someone with this disease will be like going along, definitely different than what they used to be, right? But they are kind of plateauing, and then suddenly something happens. They have an aspiration pneumonia episode, or they fall, or they get a really bad UTI, and it takes them to the hospital. Then in the hospital, they're kind of down here. They're looking really bad. They're not really eating. They're sleeping 22 hours a day. They have this infection. And while they're in the hospital, they'll get referred to hospice. They'll meet criteria when they're down here on hospice. So they go on to hospice. And then as the months go on while on hospice, they will slowly crawl back up to probably a new plateau. They won't be here anymore. They'll be down here. But after a while, they plateau again and they kind of steady out, which is good. But that usually means they won't continue to meet criteria for hospice. And we basically need to prove to Medicare that this person still has less than 6 months to live. And there's things we have to look for in specific diseases. So it can be rough. To me, dementia patients, and I'm using dementia very loosely here. But dementia patients, like there is not a program that's like for them. If any disease like falls through the cracks of our healthcare system, I feel like it's dementia patients.
Yeah, I'm sure Careblazers listening right now are saying yes.
Yeah, families really feel it because they're like, listen, we're telling you, we don't want any heroic measures. They literally can't get out of the house. We can't get medical care if we wanted it. Why can we not get someone here? And to say, it's like, I hear you. And I happen to work for a hospice company now, good or bad, I don't know, but they're really strict. They are really strict. They will follow Medicare guidelines like verbatim. Like for example, someone who has Alzheimer's disease, they look at a FAST scale. So they have to be at least a 7C or below on a FAST scale. They have to have a recent hospitalization for some kind of infection, or an albumin level. So they have to have blood work recently, things like that, where people who are like, what? They've been in bed bound for 5 years now. We haven't taken them to the hospital to get blood work. So it's like, it's tough. Yeah. I hear the families. I hear it. It's a missing link in our healthcare system for sure.
Yeah. So let's back up a bit. Let's say somebody with dementia does qualify for hospice and they get on hospice. What is hospice doing for them?
So we provide all of their medical care basically in the home to an extent, meaning they get this big package over here, which I'll go into in a second, but they don't get this package, which is like taking them to the hospital, being admitted into the hospital, which most families don't want anyway by the time they come onto hospice. But what we do give them is like a team of people. So a doctor, a nurse, social worker, home health aide, chaplain if they want it, volunteers to help them with certain like things like groceries and things like that. And then a 24-hour number that they can call day or night if they need medical assistance or something makes them nervous or there's a change in condition, right? It's kind of like their 911. Like instead of calling 911 to get an ambulance here to take them to the hospital, they can call a hospice number and a nurse can come out and check on what's going on. They get medications delivered. You know, we're kind of like at their beck and call. So I always say when people sign up up for hospice to kind of like, they don't have to, but like forget about everyone else, all the 800 numbers they used to call that were so hard to get through to anybody. Like just call this one number and talk to your nurse. You'll also have a nurse that's going to visit at least once a week. So that's the lowest of the low. Standard's usually twice a week, but once a week, technically Medicare says. So you'll have the same nurse kind of coming in week by week, just checking in on you, medication refills, checking your skin to make sure you're not developing any like bed sores, just making sure the family's okay, everything's going okay, right? Week by week, we'll check in just to kind of allow the body to be the guide and also be there if anything comes up. The home health aide can come in a couple times a week, help bathe them, change the bed sheets, things like that. I always say, I think the medical social worker and the chaplain are the most like underutilized part of the team because people think like, oh no, like no one wants to ask for help ever, especially like emotional help. They're like, no, I'm fine. It's like, no, this is a part of the team that can like help you emotionally, spiritually, just any kind of support. It might be lonely. You can't leave the house. Just to have someone, they're usually really well trained in how to interact with people and how to help in uncomfortable situations. So they can really help you. The doctor is in and out. Like the nurses are really the eyes and ears for the doctor. The doctor will come if they have to, but also the nurses are really always in cahoots and always talking to the doctors to get medication changes and things like that.
Yeah. So hearing how difficult it is sometimes for people with dementia to qualify for hospice, when people with dementia do, I know often when I worked in home-based primary care and saw people in their homes and eventually they went on hospice, people with dementia can stay at that plateau for a long time. And so as you're describing everything that comes along with hospice, which is a wonderful benefit and help, it's a great relief for the caregiver as well as a service to the person with dementia. But sometimes because they're staying so stable so long, when that reevaluation time comes up, like it's been 6 months, sometimes hospice goes away.
Yes.
Do you find this a lot in your practice?
Yes. And yeah, it's hard. If we can't, it's called like recertification. Anyone who's gone through this will know sometimes we cannot recertify because they just do not qualify. We try best we can to set families up with other resources, but it's just not the same. It's just not the same. And it's unfortunate. We try to sometimes, like my place of work, we'll try to put them on palliative care or another like home care thing so they can still have like the hospital bed and different things they need. But it's still a pain in the butt, right? Still like a bunch of like hoops you have to jump through to get things like verified and approved. And it can be really, really hard. And I wish I had like a better answer, but it's just more like, no, you're like, I think a lot of people think like, what am I doing wrong? Like, why can't we get, and it's like, you're not doing anything wrong.
I think a lot of families feel almost like it's personal. Like, why would you take this away from me? And so I just love that you're validating kind of how this works and what's going on. Many people go through this. And one of the things that I saw a lot clinically is it seemed like both the main family members and the person with dementia did better on hospice because of all of the support and care they were getting. And then when they're doing so well, hospice goes away, it starts to decline again.
Exactly. And then that is honestly, I always say like, I want you to know that like, I would never want to take this away from you. We just legally have to.
Right.
And then usually what we see, they decline. And then because they decline, they can come back on service. It's like, oh, it just doesn't.
It's hard. It's so hard.
It's like infuriating for all of us. Yeah. It's like, that's ridiculous. So now we have to wait till they decline, wait till they get a UTI. They have to go into the hospital and then they can come back on service. It's like, really?
I know it's hard.
Yeah.
It's so hard. So one of the things I felt personally, both as a professional, but also as a family member helping my mom, who's since passed away, is that hospice is not brought up soon enough. What's your opinion on this from the medical, healthcare standpoint? I remember personally, my mom had been in and out of the hospital. I mean, I can't even keep track. I'd say at least a dozen times in 6 months. And she was frail, underweight, lots of hospitalizations. To me, this was like a big red flag. Hey, can we talk about hospice? Can we bring this up? And I got a phone call back from the attending. It was like, okay, we'd like to talk to you about palliative care. Don't worry, it's not hospice, And it was I'm the one who asked the question. I'm the one who brought this up. And the response I got was, well, her vitals are good, so we don't need to be talking about hospice. And my mom was dead less than 4 weeks later. I'm a clinical psychologist. I've been in the healthcare field. I worked a
Right.
lot with hospice. And I'm like, I'm having a hard time advocating for my own mom. And it just feels like, how is anybody supposed to do this? And I think we've seen statistics that most people who get on hospice die within like a couple of weeks, even though they have 6 months technically. What is it that we don't get people on sooner?
I think it's a number of things. It's a number of things, and I don't think anyone's maliciously, I don't think you do either, but just so everyone hears me, I don't think anyone's maliciously trying to do anything wrong. I think we are like, I know this because I was an ICU nurse for many years. You get blinders on and you don't learn how to talk to people about death and dying. And also, you're not in that business, right? Like in the ICU, like we're not in the business of talking about death and dying. We're in the business of getting people better. You're in the ER, they're in the business of fixing whatever it is and getting them out or getting them to the floor. It's kind of like the buck is passed.
Yeah.
That's someone else's job. And again, like no shade to anyone truly, because I know how that feels like working in the ICU. You're afraid to be the one that you think, I can remember thinking like, am I the only one thinking this person's going to die? You know, like maybe I don't know something that the oncologist does know, or maybe, you know, so the buck gets passed. And then a lot of times too, in especially our hospital systems, there is not enough time. This is like a hurry up and care, but actually hurry up. Like there's no, like, that's a conversation that some people are really uncomfortable having. So it takes, and even for them to, like the healthcare professional, it's uncomfortable for them. They're not used to it. It would take a lot of time to sit down with family. They don't know what the family thinks. They don't know if it's ever been approached. So they need some time to do that. Time is of the essence and they don't got it. And I can tell you because I was in the ICU and there wasn't time. And that's half the reason why I hated working there. I wanted to be this compassionate, empathetic healthcare worker. But guess what? I have 2 patients that are like trying to die on me and it's really task oriented and you just can't get there.
Yeah.
So I think that's a thing too. I think they don't have enough time. And then I think we're just not trained to talk about it. We're just not comfortable talking about it. And that needs to change full stop. Like healthcare workers, it needs to be, especially people in the ER, because they see a bunch of ER things. I get it. That's like not their goal, right? So like they just automatically assume it's like not their place to be like, have you thought about hospice? You know what I mean? Because like they're the ER, but I don't think that's right. I think that needs a change. End of story. Oncologists, please, we need to start having learning how to have end of life conversations and when, not even to say when is enough is enough, but when to just say there is another path, right? Like, yes, we can do this. Yes, we can do this. And there's a third path. It's called hospice. We should start talking about it way sooner than we do. Like end of story. And then this is a soapbox. Can you tell? I can just like all of this is a soapbox. I can just go on and on and on. The last thing I'll say is because our healthcare providers are not there yet, our healthcare system is not there yet. I feel like there's a movement towards it, but we're not there. We, as the people that it's happening to, need to be the voices. Like we need to be the people to say, what about hospice?
Right.
You know, when the doctor says, don't worry, it's not hospice, we say, which I'm sure, I don't know what you said. I'm not saying you specifically, but we say, oh no, it's okay. You can talk about hospice. I was thinking hospice, right? Because we need to give them the okay to, I mean, we don't need to, but since they're not doing it, but people need to know that this is something I can talk about it. I have a whole entire chapter in my book that deals just with this because our healthcare workers aren't doing it. And because of that, we need to do it. We need to say, I want to talk about hospice. When in doubt, check it out. That's what I always say. If you're in doubt, check it out.
Yeah. And if they don't qualify, you'll be told they don't qualify, but at least you've opened up the discussion. And I think this is a thing that frustrates a lot of family members, but also it just needs to happen is we have to take on that responsibility and advocate. We can't wait around and expect that the healthcare field is going to bring up what's in our best interest all the time. I think you hit the nail on the head. It's like all of the different professions are pretty siloed off and they're focused on their one area. And it's very rare to have the step back, look at the holistic approach of what could actually help this person. And that's where the family member comes in.
Exactly. And I'm sorry to interrupt you. I was going to say, except for palliative care. I do feel like palliative care and palliative care doctors who are still kind of in the hospital, they are the ones that are trained in all of this. And that's why I always say like, they need to come in earlier too, because they're the ones being like, hello, like trying to get the cardiologist to talk to the pulmonologist, to talk to the oncologist, to get like a better understanding of what's truly happening to this person on a full person level.
Yeah. Do you think it's ever too early for a Careblazer to ask their primary care provider about palliative care if their loved one has dementia?
Oh, not palliative care, no. Palliative care is never too early, ever. Always advocate for palliative care, always. You lose nothing and you gain so much. You lose nothing. Always ask for palliative care.
Careblazers, if you're listening right now, that's a big action item, a big thing at the next appointment, or even to call and leave a message and ask about how palliative care can help your loved one with dementia.
Yes, I will say, depending on whatever facility you're at, it's either like something you can easily get on, or there's strict criteria. Specifically where I work, our palliative care does so much, but it's really hard to get on. But it still doesn't hurt, right? When in doubt, check it out. When in doubt, check it out.
Just ask, for sure. I love that. I want to backtrack just a little bit. Can you share your story of how you got to be doing what you're doing? Because I feel like it's maybe not so unusual nowadays, but it is pretty unusual for healthcare providers actively working in the healthcare field to be taking to social media and talking about, really anything in their field, but especially for you, death and dying. How did this come to be?
Oh my gosh, it was like a magical, this is why I take it seriously, but I try not to control it at all, in the sense of like, I'm just letting things happen because it really happened that way. So one, I became really passionate about death and dying and hospice care because I was an ICU nurse, like I said before, became passionate about being a hospice nurse or just doing something else, right? And as I was a hospice nurse, I've been a hospice nurse for like 8 or 9 years now. First couple years were like so eye-opening to me as a healthcare provider, because like I just didn't know. Like the body was built to die, all the amazing things that like literally is like biologically built in our bodies to help us die. It was so fascinating to me. So I really got into it, and I really got into like educating the patients that I worked with and their families about all the things that I was seeing and witnessing and learning. So I was really into it, really, really passionate about it. And over time, that's really it. I was just really into my job, which is really great. It feels so good to like love what you're doing. And about 3 years ago, it'll be 3 years in May, a really good friend of mine, his dad was dying, and it was particularly hard for him and his family. And he was just calling me on the daily. I think his dad was on hospice, but calling me on the daily, being like, oh my God, this is going on. This is going on. I just didn't understand how hard this was going to be, like all the stuff. Right. And I would like tell him all the spiels that I've like learned over the years. And I would just say my normal stuff that I would say to anybody going through this. And his reaction was so like, I can't believe I've known you for years, and I had no idea that like this is the stuff that you know and like work with every day. Like, I can't believe I didn't know this. Cause like I told you before, my everyday life, normally I'm at a dinner party and someone asks like, what do? You say a hospice nurse, and like, they're not asking questions. They're like, right. You either get like, oh, that's depressing, or like, oh, you're an angel. Like, it's just like an awkward, it's never like, tell me more about death and dying, ever.
Mm-hmm.
So I usually don't. Anyway, so he was having this experience and telling me how much it was helping him. And then he was the one who was like, you need a podcast, you need to do something with this, you need to tell people this, people need to know this. And that's what got me thinking about doing it. And then I went home. It was like right when things were opening up, post-COVID-ish, like a year or two out of it. And I went to go see my nieces. They were like 12 and 13. They were on TikTok, and there's literally video of me, which is perfect. There's video of me and them like learning a TikTok dance, and me being like TikTok, like kind of making fun of them and like getting on TikTok so I could see the videos they were making of us dancing. And I started seeing like people my age, I'm 41, like people my age, like talking about things like space and like gardening and like adult things, right? And I was like, oh my gosh, this app is like amazing. I love this. And I decided I was going to make videos, and I made a few. And I think the 4th day in, one went viral. And then like, I just kept going viral and kept going viral and kept going viral. I was just like, I guess this is the thing. I guess people are ready to like listen and hear stuff about death and dying. And then of course I saw other hospice nurses doing that. So then I became friends with them, and
love it.
All.
Yeah, I love it. People are wanting to hear what you have to say. And what I really love about the social media piece, which is very awkward and strange, like for me in the beginning, was that the people who follow and watch are the people who are the most interested in learning and the most ready, because they're actively seeking it out. Versus sometimes I felt like in the hospital, when people had an appointment, it was like, okay, another appointment, check the box. And I'm like, I have people over here lining up to hear something on social media, and you're like blowing off the appointment. I don't get, but I think it really is just this information and having access to certain experts isn't as widely available in all the places. And so having something easily accessible 24/7 where you can learn basic information, I think is so, so helpful, especially too, which I think you do really well, is just speaking in very clear ways without all of the medical jargon.
Yes, that's why I feel like I usually say no to speaking at like medical events because I'm like, it's like me screaming into a vacuum. Like anything I say, you guys already know.
Yeah.
I want to talk to like the people who don't know and talk to them like in layman's terms so we understand each other.
Yeah.
And
Exactly.
doesn't feel so intimidating.
Yeah. I love that. Although I will say, I think you have a big need to be talking in medical conferences to people because, yeah, you already know what I'm going to say, but
you're right. I honestly never thought about that. But
yeah.
That's the first time that's ever, I'm like, oh, that's right.
Yeah, because it's like training the front line who are going to be talking to family members about this. How do you get comfortable? When is too soon? I mean, I really still think the majority of the healthcare field waits until it's way too late to bring it. It's never too late, but they wait until like the last absolute minute to bring something like this up, and they're all awkward about it and they don't have to talk about it. I think you could have a really huge role there, but
something to think about.
Yeah, something to think about.
Yeah.
Okay, I want to get into some meat and potatoes, Julie. I want to talk about so many family members are worried about how dying looks.
Oh my God, yes.
Can you talk about that? Things maybe family members might want to, I know it could be different, but things family members might want to prepare for, things that are normal. For many people, it's the first time they're witnessing death.
Exactly. Yeah. So the first thing I noticed when I was started the social media thing was so many people writing to me being like, oh, just like spilling their, like my dad looked awful. It was so traumatizing. There was a gurgle. He was drowning on his secretions. He looked gaunt. He was suffocating, like all these things that they thought were going on. And the way they were describing it, I thought, oh my gosh, that person just sounds like they were actively dying. But like no one told this person that that's like how people will look and sound and the things you're going to see and why the things are happening. So it can look so scary if you don't know, and not all the time either. Some people don't. Some people look like they're just sleeping. So it just depends, right? But like people can look and do strange things at the end of life, especially during the actively dying phase, which is the last phase of life. And if you don't know what it looks like and you're not prepared and you don't understand it, you can definitely think your loved one's suffering. And then what does that do? It makes you panic. And then you're not really present with what's going on, right? Then you have this like traumatic experience.
It's very traumatizing. It can be for the family members. Yeah.
Yeah. And I never want to I also want to make sure anyone listening, like, I don't want to not validate that experience for you. Like, I don't want to be like, it's not traumatizing. I get it's definitely traumatizing if you don't understand it. And I think one of the most controversial thing that I do, which upsets me because it's not controversial, but social media tells me it is. I'm constantly threatened by social media platforms that they're going to ban me because I show real life actively dying videos. Followers of mine send me videos. Of course, I cleared legally by getting written permission, all these different things about, and I try to blur out things best I can, but sometimes I can't blur out certain things. I want people to see it. I want people to see the mouth, see the eyes, because it makes a difference. And I show these videos with a huge trigger warning, of course, is a big warning ahead of what's going on, blah, blah, blah. And then I explain what everyone's seeing. I get the most heat from social media about that, but I get the biggest response back from my followers saying, thank you so much. Like, this has really prepared me. And by the time my mom was actively dying, I wasn't afraid and I was able to understand what was happening and da, 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 da. And that is what I want, because at the end, so actively dying, what it can look like, if I just wanted to explain it, is usually, so first off, it lasts for a few hours to a few days, usually a few days, I would say. Your loved one will be fully unconscious. So they're not awake and they're not eating and drinking. Usually they will be sleeping 24 hours a day, not eating and drinking, normal, all normal. Their brain has turned on mechanisms that make them not hungry and thirsty, or technically they've turned off mechanisms that stop that hunger and thirst mechanism, and also turned on a mechanism that makes them sleep all the time. Their calcium levels are usually really high, which makes them asleep. That's something that biologically naturally happens, which is amazing to me. So they'll be sleeping or unconscious, and their eyes might be partially partially open and their mouths might be partially open. And this is all because at the end of life, all of our muscles really let go and relax. And it takes muscles to keep our mouths open and our eyes shut or even blinking. That's why their eyes may be open or their mouth may be open. The changes in breathing and then the terminal secretions, which is like the death rattle, are the things that disturb most people. So the changes in breathing can look really scary because one, they're not breathing like we would normally see someone breathe. And it can even look like they are like gasping for air, which again, like even saying that I know scares people. And I can truly say this with all certainty. This is a chemical, like a metabolic reaction to our body shutting down. We have like a very fine balance of things going on in our bodies when we're alive and well and healthy to keep us breathing the way we're breathing and the heart beating the way the heart's beating. And when that starts changing, the body will purposely breathe differently because the metabolic stuff that's going on in the blood gas. And that's going to create a different type of breath. But your loved one is so unconscious, they don't know that's happening, right? Because you can tell you can tell, believe me, coming from a healthcare worker, if someone feels like they can't breathe and they're awake enough to feel that, you will know. They will be showing you with their eyes, with their movement. They would not be just laying there sleeping and breathing like that. Also, the death rattle or the terminal secretions is not really coming from the lungs. Like it's not, people think they're drowning on fluids. Now that can technically kind of happen. It's a whole nother story. That doesn't usually happen at the end of life on hospice. What it is right now, I just swallowed saliva. So right now our body's making saliva in our mouth to keep our mouth really moist, and our brains will unconsciously swallow that saliva all day long, every day of our lives until we're in the actively dying phase. The brain's kind of shutting down. The muscles here to swallow aren't really working. It's not really communicating to swallow, but it's still creating saliva to keep our mouth moist. And then we're usually have our mouths open. So there's a little bit of saliva in the mouth is open, and then your breath's going over that saliva and creating like a gurgling noise. And people, I get it. People don't know what that is and they hate it. And it sounds awful. So I'm getting really long-winded, but it's just important to know what it looks like so you can familiarize yourself with this. So when you do see it, especially if you're trying to have a natural death at home, like it's a prepared thing, we don't want to panic then because it's a special time. Even though it can feel so sad and so hard, it still can be like a special sacred time where you can feel honored that you get to be there with your loved one during their last breaths. And of course, when in doubt, you can always call your hospice team and make sure it's all normal, but it's good to normalize yourself because if you're not used to seeing it, it can seem real scary.
Yeah. And that's where hospice can be so helpful, just to explain everything what you just did. I think it was especially helpful to say, if somebody's really can't breathe and they're aware, they're going to be moving, flailing, doing something to indicate they are suffering.
Yes.
And that's not the case for people who are actively dying. You know, we're talking about educating family members. However, I know as a psychologist going into the homes, when I was in home-based primary care, I remember the very first person I saw who was actively dying. I think he was like 24 hours from dying. His eyes were halfway open. He had the death rattle. I had never seen anything like that before in my life. And I was scared. This wasn't something that I was taught or learned or even saw until you're actually I was in there, I can still remember it very vividly, like in the living room. And here I am trying to control myself while his wife is right here with me. Like, oh my goodness, look what's happening. But we don't see it. We don't talk about it. The fact that you're sharing real life images and videos of how this looks and, discussing it, I think can be really helpful so that when it does happen, it's like, oh yes, this is the thing Julie was talking about. This is the thing that's normal.
Yes.
Mhm.
And even some of those breaths are like a natural bodily reflex. So the person is like some of the very, very end of life breaths that some people have. The person it's not even a real breath. It's like a biological reflex of the body, which I think it's really hard to like see that when it's your loved one, right? It's easy for me to say it. This is not my mom, right? Dying, at least not this moment. But I think it is important to know that there is a biology to this. So there are like, just like a baby, when they have like the sucking mechanism, it's like that. It's like, also, I always refer to like a babies can't verbalize what's wrong, but they can cry. They can be restless. They can be fussy. They can be extra lethargic. You can tell when something's wrong with a baby, even though they're not verbal. And that is like a dying person.
Yeah.
You can tell. And if you can't tell, ask a medical professional who can.
I love that. Now, we could probably talk for hours and hours about all the symptoms, maybe some of the surprising things that could happen, that you might witness. There's just so much to talk about. I know it can't all be done in this video. However, you have something really exciting. You have a book coming out.
I do. Yes. I have a book coming out June 11th.
June 11th. It's called Nothing to Fear.
Yes. Nothing to Fear, Demystifying Death to Live More Fully. There is something about, I truly mean this, there's something about understanding and preparing for death in a general way that can truly help you live better and die better.
I love that. So I know that several of our Careblazers have already pre-ordered your book. So it's available for pre-order now, right?
It is, yes.
Obviously. I will be sure to link to that in the description below, Careblazers. If you're interested in learning more about the dying process, hospice, supporting Julie and everything she's doing, please check out that link in the description so you can get your hands on this book. I'm excited to get it. Is there anything, Julie, you think that would be helpful, knowing our audience of family caregivers for people with dementia? Anything I haven't asked or anything you think that would be good for them to know as we end this talk today?
Oh, man. I think you covered a lot of it. I think the only thing I like to have people remember is, when you're laying in bed and if you're thinking about, but what about this or what about that? Or am I doing enough? Am I not doing, if you're like reeling in bed, which I know I would do that. Remind yourself or think these 3 questions. Is my loved one clean? Is my loved one safe? Is my loved one comfortable? If you can say yes to all those things, you have done enough. You have done enough. And today's a new day. Like each day, just remind yourself of that. Are they clean? Are they safe? Are they comfortable? Because people with dementia can be so tough because you want them to eat, but they won't. Or you want them to do this and they won't. Or they're doing this. And so it can be so frustrating and so hard. And you just sometimes need a reminder of like settling your brain down a bit. Are they clean? Yes. Are they safe? Yes. Are they comfortable? Yes. And now if they're not, if they're on hospice, you can call the hospice team and try to get some help. But in general, if your mind's kind of spinning like it can, ask yourself those 3 questions.
I love that. And Careblazers, please call up and ask about palliative care right away. You can even ask about hospice if you want to, but at least call for palliative care. Julie, thank you for taking the time out of your busy schedule to chat with all of our Careblazers. I'll make sure to also link to your social media. Careblazers, go watch some of those videos, take your learning even further, familiarize yourself as much as possible. It's happening to us all. We're all going to die. We're all going to witness this in one way or the other. Many of us, especially for following me, sooner probably than later. So thank you for sharing everything that you do, Julie, and it's been a pleasure.
Thank you so much. Thanks for all you do.
Thank you.
Also, Nico gets a belly rub for every person who subscribes from this video. So if you haven't already, click the red subscribe button. It's totally free, and Nico says thank you very much.